Hello, and welcome to Advances in the Diagnosis, Assessment, and Therapeutic Management of Biliary Tract Cancers, What Clinicians Need to Know. My name is Dr. Rachna Shroff, and I am a GI medical oncologist and the Chief of Hematology Oncology at the University of Arizona Cancer Center. We're going to start with an overview of biliary tract cancers and how we approach these patients. So we know that biliary tract cancers are actually a heterogeneous group of malignancies that include cholangiocarcinomas. Specifically within cholangiocarcinoma, they are divided anatomically into intrahepatic cholangiocarcinomas and extrahepatic cholangiocarcinomas, including perihilar and distal cholangiocarcinomas that fall in that extrahepatic category. The majority of cholangiocarcinomas are perihilar, with 50 to 60% being from that area and 20 to 30% being distal, 10 to 20% being intrahepatic cholangiocarcinomas. Now, what we do know is that when we look at the incidence of biliary tract cancers in the United States, we are seeing an increase in incidence. We're seeing this across the board in terms of both intrahepatic and extrahepatic cholangiocarcinoma, with a projected 5,900 cases of intrahepatic cholangios in 2023 compared to 2,800 extrahepatic. The intrahepatic cholangiocarcinoma predominance is a new shift in the epidemiologic factors. Unfortunately, biliary tract cancers are associated with a relatively grim prognosis, and that's really because the majority of patients present with what we call advanced or unresectable disease at about 80%. Those patients have to move on to systemic therapies, and the 20% in whom a surgical approach or a curative approach is an option and are resectable, unfortunately, a high percentage of those also recur, usually within 1 to 2 years. So when we look at the SEER database for 5-year relative survival rates, you will see that localized biliary tract cancers perhaps have a slightly better survival rate. But when you look at the distant disease subcategory, the 5-year survival rate is less than 5%. Understanding and identifying and diagnosing biliary tract cancers and understanding the risk factors associated with them also help us develop treatment plans and think through the patient journey for these patients. In general, biliary tract cancers are adenocarcinomas. And when we look at risk factors with intrahepatic cholangiocarcinomas and extrahepatic cholangiocarcinomas, a lot of the risk factors are really associated with chronic inflammation. And that chronic inflammation can come from things like cirrhosis or from liver fluke infections or even perhaps gallstones. Intrahepatic cholangiocarcinomas are oftentimes found incidentally or are due to more vague symptoms, while extrahepatic cholangiocarcinomas have a tendency to present with obstructive jaundice because of involvement of the larger biliary tracts. Working up and identifying biliary tract cancer patients involves a variety of different techniques, but in general should of course involve a history and physical and quality imaging. And that quality imaging should be multiphasic, contrast enhanced, either CT and or MRI with contrast, and then full staging to include imaging of the chest. Liver function tests are imperative to ensure that there is no issues with biliary drainage. And a surgical consultation is often part of the initial workup just to understand if the patient is potentially amenable to a surgical resection. Equally important in this day and age of precision oncology is to perform comprehensive molecular testing for patients with unresectable or metastatic biliary tract cancers at the time of diagnosis. Anybody who is a candidate for systemic therapy can get started on systemic therapy while that testing is ordered, because this could inform targeted treatment options and eligibility for clinical trials. It's very important to note that with the onset of novel therapeutics, approximately 50% of biliary tract cancer patients may have actionable genetic alterations that we can identify on comprehensive biomarker testing. So when we talk about systemic therapy for unresectable and metastatic BTCs, the NCCN guidelines have clear preferred regimens for newly diagnosed patients. And those preferred regimens involved a gemcitabine and platinum backbone, gemcitabine and cisplatin typically, with the addition of immunotherapy, either in the form of durvalumab or pembrolizumab. So what is the data for how we approach newly diagnosed biliary tract cancer patients? Well, this dates back to the initial ABC02 study, which was a large randomized phase 3 trial of gemcitabine with the addition of cisplatin versus single-agent gemcitabine for newly diagnosed biliary tract cancer patients to include cholangiocarcinoma, gallbladder cancer, and ambulary cancer. 410 patients were enrolled across 37 centers in the United Kingdom. And you can see here on this Kaplan-Meier that the addition of cisplatin to gemcitabine improved median overall survival from 8.1 months to 11.7 months with a hazard ratio of 0.64. Similarly, median progression-free survival was improved from 5 months to 8 months, and the overall response rate with the doublet gemcitabine and cisplatin was 26.1%. That was our historical benchmark for over a decade, until we realized that the addition of immunotherapy to this chemotherapy backbone has the potential to improve outcomes. These were found with 2 pivotal trials, the TOPAZ-1 study, which involved 685 patients and was a large randomized phase 3 trial, as well as the KEYNOTE-966 study, which involved 1,069 patients, again, international randomized phase 3 trial. The population was very similar in both. This involved all biliary tract cancer patients, intrahepatic, extrahepatic cholangiocarcinomas, and gallbladder cancers. On the TOPAZ-1 study, the investigational arm was gemcitabine and cisplatin with the addition of durvalumab, and the control arm was gemcitabine and cisplatin with placebo. On this study, Gem-Cis was given up to 8 cycles, and then durvalumab was used as a maintenance regimen until the time of progression versus placebo. And the primary endpoint here was overall survival. In comparison, the KEYNOTE-966 study involved gemcitabine and cisplatin plus pembrolizumab, and that was compared again to gemcitabine and cisplatin with placebo. And in this case, again, gemcitabine and cisplatin was continued for 8 cycles, but the maintenance arm here was gemcitabine continued with the pembrolizumab or immunotherapy maintenance. Again, primary endpoint was overall survival. And when we look at the key efficacy and safety outcomes, you will see that with TOPAZ-1, the median overall survival was 11.5 months versus 12.8 months when you added durvalumab. The KEYNOTE-966 median overall survival was 10.9 months versus 12.7 months. So in general, slightly over 12 months was the median OS when we used a chemo-immunotherapy combination. Overall response rate of Gem-Cis Durva was 27% versus 29% in Gem-Cis Pembro. And importantly, you will see that there were expected immune-mediated adverse events, but very few treatment-related adverse events led to discontinuation in the TOPAZ-1 study at 8.9% of patients in Gem-Cis Durva. This was slightly higher in KEYNOTE-966 at 19% of patients. The most common adverse events were what we would expect typically from the chemotherapy component, including decreased neutrophil count, anemia, as well as nausea. Importantly, we have now seen long-term follow-up data from TOPAZ-1 with a median follow-up of 41.3 months. And what you see here is that the Kaplan-Meier curve at the 3-year analysis stays true with the separation of the curves, a hazard ratio of 0.74, and a median OS of 12.9 months with Gem-Cis Durva. No notable changes were seen in terms of safety signals. Similarly, the KEYNOTE-966 3-year data shows a median follow-up of 36.6 months, and here, Gem-Cis plus pembrolizumab median OS was 12.7 months with a hazard ratio of 0.86. And again, comparable safety profiles and no significant changes or signals that we should be worried about. So let's look at a case and apply some of our knowledge now. Jonathan is a 64-year-old man with a history of primary sclerosing cholangitis who presents with painless jaundice and has mild right upper quadrant tenderness to palpation. His labs are notable for a bilirubin of 3.2 and an elevation in his AST and ALT as listed. CT imaging shows a perihilar mass in the liver with left-sided biliary dilatation and multiple bilateral 8 to 10 millimeter lung nodules. ERCP shows a 1 centimeter stricture in the left hepatic duct, and a biopsy confirms adenocarcinoma that is CK7 positive, CK19 positive, CK20 negative, and CDX2 negative. The correct diagnosis here is a metastatic extrahepatic biliary tract cancer, and that is because this is a perihilar stricture that is biopsy proven to be an adenocarcinoma, and there are multiple pulmonary nodules noted, making this a metastatic situation. Here, options could include gemcitabine and cisplatin with either durvalumab or pembrolizumab, and in specific situations, consideration could be given to gemcitabine, cisplatin, and nab-paclitaxel. That being said, per NCCN guidelines, assuming good performance status and good kidney function, liver function, the preferred regimen would be B, gem-cis with either durvalumab or pembrolizumab. And again, that's really based on the TOPAZ-1 and KEYNOTE-966 data that shows the longest median overall survival that we've seen to date in this disease of just over 12 months, and improvements in other important efficacy outcomes such as progression-free survival and overall response rate. So Jonathan is started on gemcitabine, cisplatin, and durvalumab, but unfortunately, after 3 months of treatment, he has an increase in the size of his perihilar mass, and 2 new pulmonary nodules are noted. At the time of his diagnosis, we had ordered comprehensive molecular testing, and in fact, that testing did show that he had a HER2 amplification. Molecular testing obviously opens up a number of targeted therapy options, and so now let's discuss the role of targeted therapy in treating this disease.
My name is Lipika Goyal, and I'm the Director of Gastrointestinal Malignancies at the Stanford Cancer Institute. It's my pleasure to be giving this talk, and there's so many new targeted therapies that we can offer to our patients with biliary tract cancer. It's a new thing in the last couple of years that we're excited about, and there's more research going on each year with more targeted therapies getting approved. Cholangiocarcinoma is a target-rich cancer. This is from a review article by Angela Marca back in 2020. As you can see, FGFR2 alterations are seen in about 15 to 20% of patients with cholangiocarcinoma. IDH1 mutations are seen in about 15 to 20% of patients. And this is specifically in patients with intrahepatic cholangiocarcinoma. We also see HER2 overexpression amplification, BRAF mutations, and a few other targets. And now, just last year in 2023, there was another review article published, and you can see that the number of alterations is expanding. The FGFR2 rearrangements, this particular study showed that it was seen in about 9 to 10% of patients, with FGFR2 mutations being seen in about 2.2% of patients. And you can see that we now see MDM amplification on here. We see not just HER2 overexpression and amplification, but also HER2 mutations. We see MET. So there are a series of different alterations, and we now have drugs that are targeting MDM, which will be talked about later in the program. Because cholangiocarcinoma is such a target-rich cancer, the standard approach for patients with biliary tract cancers who are candidates for systemic therapy is to get sequencing of their tumor. We used to treat cholangiocarcinoma very similar to gallbladder cancer, and intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, gallbladder cancer, we gave chemotherapy across the board. But now that we have these molecular alterations that we can assess, we find that there's different frequencies in the different tumors, and it's important to be able to see what other therapy options there are beyond chemotherapy. So it's important to use a comprehensive panel that looks for all of these different alterations. And it's important that in some patients where we do a biopsy and there isn't enough tumor content in order to be able to do the molecular profiling, that we can also do liquid biopsies. So here's a little bit about next-generation sequencing for biliary tract cancer. The ideal platform is one with a short turnaround, one that is comprehensive and covers a wide range of detectable alterations. And we normally, our first choice is to do it on tissue biopsies, but in some patients, as I mentioned, where the tissue profiling fails, we can also do it on plasma using a liquid biopsy and looking at circulating tumor DNA. And we can sequence circulating tumor DNA. These platforms are often a little bit smaller, and they often do not pick up FGFR2 fusions or other fusions as well. But it's a good alternative in a patient who you're not able to sequence the tissue. This is what the NCCN guidelines look like now. before, this was largely a white page, and we had gemcitabine, cisplatin, and a few chemotherapy options. But now in 2024, as you can see, there are a lot of very specific targeted therapies and immunotherapies based on what we find on sequencing. So again, you'll hear me say it many times, but the importance of sequencing all of our patients that have biliary tract cancers. This talk is mainly going to focus on what are the approved drugs for patients with biliary tract cancers that are targeted therapies. So we have 2 targets with FDA-approved therapies that are specific for cholangiocarcinoma. And then we have 6 targets with disease-agnostic approvals. Multiple of these are targeted therapies, and for 2 targets, they're immunotherapies. I'm going to start my talk by focusing on the cholangiocarcinoma-specific approvals, and I'll start by talking about what we have for FGFR2 fusions and then what we have for IDH1 mutations. So let's start with FGFR2 fusions. These are detected in about 10% of patients with intrahepatic cholangiocarcinoma, and the very first drug ever approved for cholangiocarcinoma was pemigatinib, which is a reversible FGFR 1 through 3 inhibitor, and the response rate was 36%. This was a remarkable achievement because when we use second-line chemotherapy, which is FOLFOX, the response rate is 5%. When you use other second-line chemotherapy, such as FOLFIRI, 5-FU Nalieri, the response rate is also single digits. So the fact that we had this targeted therapy approved in 2020 for our patients really gave patients an option to have a non-chemotherapy option that has a high response rate compared to chemotherapy. You can see here the median progression-free survival was 6.9 months, and the median duration of response was 9.1 months. Again, this drug targets FGFR 1 through 3 and doesn't target FGFR 4 as strongly. The side effects of this are going to be discussed on a future slide. The futibatinib drug is another drug which is an irreversible inhibitor, so it covalently binds to the cysteine residue in the P loop of the ATP binding domain of FGFR2. And for this drug, the response rate was 42%, and you can see here the median progression-free survival was 9 months, and the duration of response was 9.7 months. Both of these drugs were tested in a population of patients with FGFR2 fusion or FGFR2 rearrangement positive cholangiocarcinoma. Futibatinib was specifically an intrahepatic cholangiocarcinoma, and all these patients had prior treatment with at least 1 line of systemic therapy. And so in the refractory setting, to have response rates of 36% to 42%, we were very encouraged by this. So FGFR inhibitors certainly show efficacy for our patients and our shrinking tumors, but it does come with some side effects and adverse events. 2 key side effects I want you to know about are hyperphosphatemia and the potential for retinal toxicity. In terms of hyperphosphatemia, that's because we're hitting FGFR1 along with FGFR2, and it's an on-target, off-tumor effect. With the hyperphosphatemia, we sometimes see phosphorus is greater than 5, even greater than 7. I tend not to worry about it too much unless the hyperphosphatemia is greater than 6 or 7, in which case I do different maneuvers such as giving phosphorus-lowering drugs, make sure people are hydrated, make sure people are moving their bowels, so they're excreting phosphorus in their urine and their stool. Drugs like Sevlim are phosphorus binders that people can take with their meals to have them stool out the phosphorus. And then for the retinal side effects, people can have retinal detachment. They can have increased lacrimation and dry eyes with their eyes. They can have growth of their eyelashes or trichomegaly. So we do have people get a baseline eye exam before they start on FGFR inhibitors. And then what people will complain about is, Doc, I'm seeing some floaters, I'm seeing some halos in my vision. That is signs that people are having retinal side effects. We normally stop the drug, send them back to ophthalmology. These retinal toxicities are usually grade 1, grade 2, and you can often just restart the drug after 3 days or when the side effects resolve. I often start at the same dose. For many patients, these side effects don't recur. In the patients where it does recur, we sometimes do a dose reduction. Now moving on to the next target with the cholangiocarcinoma specific FDA approval, IDH1 mutations. These are detected in about 10 to 15% of intrahepatic cholangiocarcinomas, probably about 1 to 2% of extrahepatic cholangiocarcinomas, and very rarely in gallbladder cancers. This was a randomized phase 3 study of an IDH1 inhibitor called ivosidenib in a 2-to-1 fashion against placebo. And this was in patients with histologically confirmed cholangiocarcinoma with an IDH1 mutation that was centrally confirmed, and they previously were treated with at least 1 to 2 lines of therapy. And this trial, the median progression-free survival was the primary endpoint, and crossover was allowed. So you can see here in the ivosidenib arm, the median PFS was 2.7 months, and the hazard ratio compared to placebo was 0.37. So a very positive study. But as you can see, the median progression-free survival, as mentioned, was 2.7 months. In the placebo arm, it was 1.4 months. So not an absolute large difference. But when you look at the progression-free survival at 6 months and 12 months, you can see that it was 32% and 22% in the ivosidenib arm. And there weren't any patients in the placebo arm that were progression-free at 6 and 12 months. And when you look at the median overall survival, you can also see a separation of the curves. It wasn't statistically significant, but when you do the statistical analysis and you adjust with the RPSFT, then you can see with the ivosidenib arm, the median overall survival was 10.3 months. What are the side effects that we see with the IDH1 inhibitor ivosidenib? Overall, it's a very well-tolerated drug, and that's why they were able to do a placebo-controlled trial, because there's not a significant amount of side effects with ivosidenib. The main ones are GI side effects, such as nausea, diarrhea, fatigue, some abdominal pain, some decreased appetite. But overall, people tolerate this drug very well. The one thing to know with this drug is that I do monitor for QTc prolongation, because that is something that we see with this drug. And you want to use QTc prolonging agents like ondansetron with caution in this population. Also, sometimes these patients get cholangitis and they need to go on fluoroquinolone, such as ciprofloxacin. It's another QTc prolonging agent, something to watch out for when combining with this drug. So what are the takeaways for FGFR2 fusions? We have 2 FDA-approved drugs. For IDH1 mutant cholangiocarcinoma, we have 1 FDA-approved drugs. The key side effects for the FGFR inhibitors are the hypophosphatemia. We see some nail disorders also. People can get some brittle nails and some nail lifting. They can get mucositis, hand-foot syndrome, and retinal detachment. Everyone needs a baseline eye exam. With the IDH inhibitor, people can get some GI side effects such as nausea and diarrhea. And in terms of monitoring for the FGFR inhibitors, as I mentioned, the eye exam, serum phosphorus, and for the IDH inhibitor, serial EKGs. Let's briefly talk about the 6 other targets with disease-agnostic approvals. I'll only go into depth with the HER2 inhibitors, and the other ones I'll have a summary slide. But it's really encouraging that a lot of these targets are seen across multiple solid tumors. And because they are uncommon, a lot of these were studied in basket studies, and then they got disease-agnostic approvals, which helps many different patients, especially patients with rare cancers such as biliary tract cancers. As many people know, for HER2, we now have a disease-agnostic approval for trastuzumab deruxtecan. Everyone should be tested with immunohistochemistry for HER2 positivity. And the Destiny Pan-Tumor 02 study had patients with biliary tract cancers and patients with HER2 3+ by IHC at a 56% response rate. The patients who had IHC 2+ had a 0% response rate, but certainly something to be testing for all of our patients. We also have multiple other options. Trastuzumab pertuzumab is on the NCCN guidelines. Zanidatamab is up for consideration of FDA approval later this year. Trastuzumab and tucatinib also was positive in a study. These are all single-arm studies or basket studies, but they all showed a response rate somewhere between 20% and 47%, and even up to 56% when you have IHC 3+. So sometimes HER2 amplification is tested on NGS panels. We also test by IHC to look for HER2 expression for the protein expression. So this is a summary of the multiple FDA-approved therapies that we have in biliary tract cancer. Again, FGFR and IDH at the top, and then all of these other targets, good to be testing for them. Some of them are quite rare in biliary tract cancers, But when we see them, we see quite high response rate, for example, for NTRK fusions, for RET fusions, and then for people who have MSI high tumors or are they deficient in mismatch repair protein expression, TMB high, all things to consider for our patients. So again, emphasizing the importance of sequencing tumors. So let's move on to a case. This is a patient of a 37-year-old woman that I took care of that presented with abdominal pain, and she was found to have a 6.1 centimeter liver mass. She went to the emergency room. She eventually had a biopsy, and this showed intrahepatic cholangiocarcinoma. Overall, it's really important to do comprehensive testing for patients. So in addition to doing a comprehensive next-generation sequencing panel to look at the DNA level, it's important to do mismatch repair and MSI testing, and also to do HER2 testing by IHC. And when we choose an NGS panel, it's important that there is good fusion coverage to make sure FGFR2 fusions, NTRK fusions, RET fusions, these are all assessed. Many assays now also do RNA sequencing and do whole transcriptome sequencing. This is a great way to pick up fusions. But overall, it's important to be testing for all the targets that we talked about in today's presentation. This patient was found to have an FGFR2 fusion, and the tumor was microsatellite stable. And the correct answer is D, futibatinib or pemigatinib. These are the two drugs that are FDA approved for FGFR2 fusion or rearrangement positive cholangiocarcinoma, like this patient had. If the patient had HER2 overexpression or an IDH1 mutation, of course, we would have chosen a different option, but this is what we recommend for this patient. And again, we would be doing a baseline eye exam. We would be serially checking the serum phosphorus. Another option we could consider is chemotherapy, such as FOLFOX, but when someone has a target, I normally opt for targeted therapy. After 2 months on the regimen where the patient got futibatinib, the patient had no disease progression. She's had some adverse events. What would you do to manage them? So it depends on which adverse events the patient had. If they had mucositis, I will often recommend salt water or baking soda gargles a couple times a day, and or if they need escalation from that, dexamethasone mouthwash. If someone had hyperphosphatemia, I recommend Sevelamer or different kinds of phos binders, and then making sure they're well hydrated and we're managing their constipation, so they're excreting their phosphorus. If they had retinal detachment and they were complaining of floaters, I will stop the futibatinib and ask the patient to see ophthalmology again to do an eye exam. As soon as the symptoms resolve, I will often restart the futibatinib at the same dose and only go to a decreased dose if they had recurrent symptoms on rechallenge. So we often manage these patients in a multidisciplinary fashion with the benefit and help of the ophthalmology team. Sometimes if they get hand-foot syndrome, we manage them with the benefit of the dermatology expertise. If they get issues with their nails, we often send them to podiatry. So it's really great to have a team approach to helping manage these patients. Overall, targeted therapies are very important for patients with biliary tract cancers because they certainly can improve outcomes. This was a study done by a team showing that when people get targeted therapies, they certainly can get improved overall survival compared to patients that don't have any actionable targets. So takeaway from today's presentation is do comprehensive next-generation sequencing for all of our patients and see what doors that opens for different therapies. Thank you very much.
Hi there, my name is Mike Pishfine. I'm an associate professor at Johns Hopkins University, and today I'm going to be talking about emerging targeted therapies for biliary tract cancer, focusing specifically on MDM2 inhibition and looking at other promising targets as well. MDM2 is a gene that's amplified in a distinct percentage of biliary tract cancers, about 5 to 8%, which is not a small number necessarily, and the percentage of biliary cancers that can have MDM2 amplification, like other mutations in biliary tract cancer, can vary depending upon the anatomical location of the underlying disease. What MDM2 is, it's a negative regulator of p53, as we'll go over in a second, and when there's overexpression of MDM2, that can lead to inactivation of p53, allowing for cancer cell growth. And interestingly, there's actually been limited overlap with other types of mutations. So MDM2 stands for murine double minutes, just the name of the gene. And the way that it functions to facilitate the degradation of normal wild-type P53. So P53 is a known tumor suppressor that has several functions in suppressing cell proliferation and cell growth and also metastases. And so when there's too much MDM2 enzyme due to gene amplification, it will cause an improper undue degradation of P53, and there's not enough P53 around, and that will lead to an unrestrained cell growth. Of course, for the MDM2 inhibitors to work, they need to work in the context of a normal wild-type non-mutated P53, because if the P53 gene is mutated and non-functional anyway, then blocking the MDM2 enzyme really won't make much of a difference. And there are several ongoing studies with MDM2 inhibitors. As I mentioned, MDM2 inhibitors are now actively in clinical trials. Most of them are very early on in early phase clinical trials, but we are starting to see some of that data. For example, Dr. LaRusso published a phase 1A study of an MDM2 inhibitor called brigamadlin. This was a publication of 54 patients treated with brigamadlin. Not all of them had MDM2 amplification, but as you see from the waterfall plot, most of them did. And there was a confirmed objective response rate of 11%. Again, most of them in those who had MDM2 gene amplification. There was an additional stable disease rate of up to 63%, with some of those patients with stable disease having durable stable disease for a prolonged period of time. Dr. Yamamoto presented an update of this data focusing specifically on patients with advanced BTC, and there were two arms to this particular update of the trial, one arm of monotherapy brigamadlin, and then a combination study of brigamadlin with the PD-1 inhibitor azabelamab. And as you can see again from the waterfall plots here, there were definitely clear responders. And in fact, looking across these two cohorts, the response rates to brigamadlin-directed therapy was 50% in this BTC population. Based on these promising early data, there is an ongoing phase 2 trial of brigamadlin across several disease types, but including a cohort that's specific to BTC patients. The study is ongoing recruitment. The estimated completion date is probably going to be somewhere in early 2025, and the primary outcome of the study is objective response. Moving on to other emerging therapies in BTC, we've known for a long time that up to 20% of patients with biliary tract cancers have alterations in the DNA damage response and repair genes, or the DDR genes. And some of these patients can have a response to targeted therapies such as PARP inhibitors, particularly those who have an underlying BRCA1 or BRCA2 mutation. And because of this, there are actually ongoing clinical trials to assess the efficacy of PARP inhibitors in biliary tract cancer, particularly those with BRCA1, BRCA2 mutations. Another promising target is MTAP deletion. MTAP is a gene that actually is necessary for purine biosynthesis that allows a cell to grow and divide. And when the MTAP gene is deleted and this enzyme is lost, the process of purine biosynthesis becomes highly dependent upon two other genes or two other enzymes, MAT2A and PRMT5. And this is important because up to 35% of biliary tract cancers can lack the MTAP gene expression. The gene is deleted. And when this happens and a pharmacologic inhibition of PRMT5 or MAT2A occurs, it sets up something called synthetic lethality, where MTAP gene loss combined with either PRMT5 or MAT2A pharmacologic inhibition will lead to the inability to create these necessary purines and lead to cell death, in this case, cancer cell death. And there are ongoing active trials looking at MAT2A and PRMT5 inhibitors, and they are recruiting patients across disease types, including in biliary tract cancers. So hopefully we've started to show you a picture that actionable mutations do exist in biliary tract cancer, and these are certainly not rare. By definition, rare is less than 1 in 2,000, but actually in biliary tract cancers, anywhere from 20 to 40% of all biliary tract cancers will harbor some clearly actionable biomarker mutation. And we know from data specific to biliary tract cancers that when the testing is done, an actionable biomarker is identified, and that patient gets access to the appropriately targeted therapy, there's a clear survival benefit. The problem is that this is not necessarily happening as much as it should be. Not all patients are being tested, and even when they are getting tested, they're not getting access to the appropriately targeted therapy, often because it's an off-label therapy or because the therapy is only available in clinical trials. So one of the things we need to do to really try and change this algorithm is to increase the testing rates. In my opinion, there really should be reflexive next-generation DNA sequencing as well as RNA testing for the presence of fusion genes at the point of diagnosis, in the same way that we might test breast cancer patients for ER, PR, and HER2 from the very get-go. We should also be looking at patients that have a quote-unquote likely cholangiocarcinoma diagnosis. Those patient tumor samples should be reflexively sent for NGS as well as probably RNA fusion testing from the get-go. And because tissue is often an issue for biliary tract cancers, if there's not enough tissue, then there's also good data of using blood for circulating tumor DNA testing. The key thing there is that the blood has to be sampled before the patient starts any kind of therapy to be able to have adequate ctDNA in the blood to do the NGS and RNA fusion testing. So thank you very much for listening, and I hope this has been helpful.